I'm Dr. Kenneth Palestrant. I'm the medical director and the CEO of Pinnacle Wellness Group. MAT is an acronym for Medication-Assisted Treatment, which essentially provides medications on an outpatient basis to patients, to people who are addicted to opiates. The medications that we use are primarily Suboxone, which is buprenorphine mixed with naloxone. We also use Vivitrol and Sublocade, which are injections given on a monthly basis. Anybody who is addicted to opiates is a good candidate for MAT. There's also utilization of Vivitrol for alcohol. So people who are alcoholics, alcohol abuse, they can come in and get a shot once a month, and it works very effectively. So I would say there's a wide population. Anybody who has any opiate addiction and alcohol addiction, MAT works remarkably well. Basically, the person comes in. We ask them to stop taking their opiates, short-term opiates, that is, such as their Percocets and hydrocodone and things like that, or heroin, for about 12 hours prior to them coming into the clinic. So we want them to come in mild withdrawal. What we do is we do an induction here in the clinic with titrating doses, a small dose of Suboxone, which is, the Suboxone is actually, it comes in a pill form, but most commonly it's a film that's placed kind of in the buccal cavity, like right up about the cheek, and it's absorbed. So we give them an induction. We titrate the dose based upon what's called a COW scale, comprehensive opiate withdrawal scale, that we use certain measurements for. And once they're feeling better and their withdrawal symptoms have gone away, they will be sent home with a prescription for probably about a week's worth of medication. They'll be brought back in about a week, see how they're doing, make sure that their cravings have been alleviated, make sure that they're doing okay, and then if they need any adjustments to their medication will be adjusted. Each time that they come in, they'll have a drug screen done, because we want to make sure they're not abusing other medications. We also want to make sure that they're taking the buprenorphine. So the drug screen actually will measure whether or not they have buprenorphine in their system, so they're not diverting these particular medications in any other way. And then if they're compliant and they're taking the medication and they're doing well and they're regaining their position in society, I guess you could say, whether it's school or family or jobs and whatever the case may be, we see them on a monthly basis. And they may stay on the Suboxone for months. There's people here who've been on it for years. It's all dependent upon the individual person. There was a lot of talk in the past of taking MAT and titrating it down, that we had to basically start them out, get their cravings under control, get their symptoms under control, but then we had to start titrating them. Okay, that doesn't exist as much anymore. There's patients who've been on MAT for years, so we have to look at it a little bit differently. As medical professionals, if somebody comes in and, let's say, for example, they're diagnosed with diabetes and we start them on insulin, and then they do all these lifestyle changes to reduce their sugar, they lose weight, they change their diet, they do some exercise, but their sugar has improved, their hemoglobin A1C, which is a measurement of their glucose control, has improved, but they still need a small amount of insulin. We're not going to say, well, listen, you've been on insulin for 8 to 12 months here, and we have to stop. No. So we have to kind of look at MAT, buprenorphine in particular, as that in that same light. It's just a little bit different kind of mindset. Well, we have Pinnacle Wellness here, which we're open 5 days a week. It's outpatient medication treatment. There are some other facilities in town. I don't know what their capabilities are, how many patients are able to handle, those kind of things. there's people, if they Google MAT, Suboxone, usually they can find somebody in their area. There's several practitioners who do it as part of their practices. We here at Pinnacle, primarily, this is all we do, is MAT and treatment of those kind of individuals. You know, the buprenorphine is not, it's an opiate medication. I have not heard of anybody who has been addicted to buprenorphine, even patients that we withdraw from buprenorphine. So it's not really, it's a unique type of medication. It has a very high affinity for the mu receptors in the brain. So we have to be very, very careful when somebody comes in and they're on a long-acting type of opiate, such as fentanyl or methadone. If we were to administer the Suboxone, the buprenorphine, it would essentially displace those opiates from these receptors and put them into precipitated withdrawal. So the buprenorphine has several different. It's got a couple of different main effects. One of them being that it has this high affinity for these mu receptors, which prevent the other drugs from locking into them. So while they're on buprenorphine and they were to inadvertently or purposely take some heroin, fentanyl, they would not overdose. So it protects them from dying from an overdose. In addition to that, it allows their brain chemistry to normalize. So they don't get addicted to this medication. This medication is essentially assisting their brain in its natural healing process. And you know, they've done studies that show with different PET scans and things like that, there's actually architectural changes within the brain for 8 to 12 months post addiction. In other words, somebody who has been addicted, been on buprenorphine for the 8 to 12 months, it takes that long at least, sometimes even longer, for those brain changes to normalize. The medical community, for the most part, which I'm part of, and had this kind of thought process for many, many years, is that we always looked at somebody who was addicted as a moral or a social failure. You know, he's a alcoholic, he's a drunk, he's a drug addict, whatever the case may be. It's as we look into the causes and the relationships and things like that, and understand addiction medicine, we have to look at it as a number one, as a public health crisis, because we've got double the amount of overdose deaths in this country than we had even a couple years ago. It's not going away, so it's a huge public health crisis. The death of an individual is like dropping a pebble in the pond. The waves reverberate out into families and communities and who knows what else. So that in itself is significant, the public health crisis part of it. But the medical community has to look at it from the standpoint of a medical condition. And as I had related before, somebody who has hypertension or has diabetes, and we get that under control, we're going to try to get them on the lowest dose, but they may need to stay on it. So the perception, the way I look at it, if we have somebody who has been addicted to opiates and they're involved in the criminal justice system and they're doing criminal behavior to get medication, money for their medication, or whatever the case may be, and they've been able to, with use of MAT, turn their life around, become more productive members of society, get a job, get their families back, reduce the criminality. I think it's a win-win, not just for the patient, but it's also a win-win for society, the local communities in general. And I think as medical professionals, we just have to try to understand that.